Hey, Marcos.
Hola, John.
¿Cómo
Hello,
estás?
John. Very good. John, I'm going to log out just for a second because my camera is
Okay.
not coming on. I'm coming back just in a few seconds.
Okay.
Okay, good.
Whoa. Hey, Marco. Hello, Marco.
Hello, John.
Hey, Marco, listen. Listen, this is going to be a good opportunity for you. Because I've been in a webcast before with a tool where not many people have showed up. He still does a presentation and you get almost personal attention. Do you know what I mean? We had two or three guys from India, but he still did the whole thing. And he took quite, you
Okay.
know, like, so use it, use this. You're gonna have a tool as like a tutor today.
Okay, good.
So
Good,
you're
that
lucky,
would be amazing.
you're lucky because I've seen him in action. He'll do it. We just need to get a couple more, but he'll do it.
Okay,
It
John.
was
Perfect.
with Hyperion when I was doing them with Hype. Yeah, we did some with the tool, and some days it wouldn't be many, but he'd still go ahead and do it. So
Okay,
okay, I'll be back.
okay, good.
This is Abby.
Yes,
Hello,
John,
hello, Abby. How you doing?
I'm good.
Good. We'll have people come. They always come late.
Yeah.
But I was telling Marco, the king will still teach no matter what.
Yeah.
I've seen him. I've seen him when I did him with Hype. We'd have two people there. He'd
Yeah.
still go ahead and do it. And I was amazed. I thought he'd say, no, you know, well, we're gonna wait, but no, he did it. And those kids were lucky that day.
Yeah.
Just like I was
Personal.
telling Marco, you're lucky today. You may get some good tutoring.
Hi, Marco.
Yeah, hello. Good afternoon.
Good night.
Actually, well, yes, yes, true. It's night for you in India. I was having a really good chat with one of my best friends. He's a neurosurgeon too, regarding to the last conference Professor Atul Goyal gave, and it was it was really was a lot of things to process.
Yeah, lot of concepts, huh? New concepts.
Yeah, it's a whole new world that Professor Atul Goyal is bringing, which is something good to analyze and to sit down and read all the articles he wrote and have like a bigger picture of what he is bringing. So this is really amazing. This is a good opportunity to have him on board and get to know all of this kind of information he's bringing.
Oh, Harshad's here. He's a regular. So this is a bunch of old friends meeting on a Sunday. Atul speaking in China next Sunday, right? Is that confirmed? Abby?
Yeah, it's confirmed.
He'll get a good crowd there because they advertise the medtion.com, the website that does all the broadcasting in China. It does a lot. They put it on the internet. They put it on their website. They get a lot of people. I think we'll probably have at least 1,000. We should have 1,000 for Tool. We just had 300 for Mike, but normally, like when you hug, it's like 3,000, 2,000. So,
Okay.
yeah, the numbers are different there. Wow. So what you been doing, Abby?
Nothing much. Working.
You don't travel with the king, right?
Not all the time.
No. Oh, here he is now. Hey, good day, Harshad.
Hi, John. How are you?
You may have a personal tutoring session from Atul.
Yes.
Hey, Atul, how you doing?
Very well, John. How are you? Good morning to you.
Listen, we'll get people coming as it goes on. But
Yes.
I was telling Marco, I say, look, Atul will teach just as good for 2 people as you will for 1,000. So don't think that you're going to be shortchanged. Please tell me I'm right, Atul.
Yeah. Perfect, my dear John. Let's talk to whoever is interested, whoever wants a different perspective.
Okay, you're at Mumbai now, right?
Yeah.
When's your
I
next
thought
foray?
Atul, I thought you were in Belgrave.
No, I didn't go.
Oh, you were going to go. Wow, to Belgrade. That's a big EANS, right? Or Europe?
That's right.
Yeah, the gentleman from let's see what country is running that. Well, the name he's a nerve specialist, peripheral nerve. Well, the name is
Rasulik.
Yeah.
Lucas,
right, Lucas. He has quite a team helping him over there. Okay, you want to start, Atul? You want to wait, or what do you want to do?
Whatever you suggest, John, whatever.
Yeah, we'll just wait a few minutes. Wait a few minutes here. Let me make.
How many neurosurgeons are there in Cuba?
Well, so far it's me. Maybe, but I think during the conference they are going to join us because everybody knows that.
So this lecture is 1-to-1.
I think, yes, I think everyone was amazed by the last conference. They still like processing.
Yeah.
Actually, I'm still processing all the information.
Okay.
Well, Cuba doesn't have good bandwidth in some places at all. So a lot of people watch it on the YouTube because they don't need to use Zoom. because we put it on YouTube, so they watch it on
Actually-
YouTube.
Actually, right now, John, we have 6 people watching it on YouTube right now. It's most of them are Cubans that they connect through the YouTube channel, because it's hard to connect through Zoom, because Zoom is blocked in Cuba, so they have to use a different channel, and the channel they use is YouTube. So that's another reason why we don't have too much.
I just had a group that they were using YouTube and using chat. They interact with the speaker, and it was very effective. So that the people with bad bandwidth can connect to the speaker through YouTube. So hopefully we'll have some connections there. Yeah. So let's start off, Tool. Okay?
Yes, let's begin.
Let's begin. Okay. Here, 10,
At least
9,
Harshad
8,
is there, my friend.
10, 9,
Yes,
8,
sir.
7, 6, 5, 4, 3. Good day, this is Dr. John Bennett, broadcasting from Miami Beach, home of Neurosurgical TV. We are honored with the presence of the King, Atul Goel, a well-known neurosurgeon, a well-written neurosurgeon from Mumbai, India. He's going to talk about, probably about the spine, but whatever he wants to talk about. So I'd like to welcome, well, let me say hi to Marco. I should have let you do this. So why don't you make an introduction too? Go ahead, Marco.
Okay, thank you, John. Good afternoon to everyone. Good morning, good night, Professor Goel. I know he's in India right now. It's near to 8 p.m. So I would like to introduce Professor Goel, that we had the opportunity to have him with us last week with this amazing conference, and this incredible new concept that he is bringing to the neurosurgery, and actually it's something quite amazing. And we have the opportunity back today to have him with us. So we are going to be amazed again. This is going to be another life-changing and mind-changing concept he is bringing us today. So it will be an honor to hear you, Professor Goel. This is your platform. Go ahead and let us enjoy your conference.
Thank you, Marco. And I await your invitation to visit Cuba someday for sure. So today what I have decided to talk on pituitary tumors. And pituitary tumors are, every neurosurgeon on the planet likes to do pituitary tumors. I have never heard of any neurosurgeon who says, I don't like pituitary tumors, or I don't want to do pituitary tumors. Pituitary tumors are important part and parcel of our life. It is very important to understand pituitary tumors because they are not easy. That is one. Surgery is not easy. Number two is surgery is game changer. Surgery can completely change the perspective of the human being. So my understanding of these tumors, I'm going to relate here today. So pituitary tumor has a very critical location in the vicinity of cavernous sinus, in the vicinity of paranasal sinuses, in the vicinity of carotid artery, in the vicinity of chiasma, and things like that. And we have written quite significantly on the location of pituitary gland, whether it is neither intracranial nor extracranial. So this is a very unusual location of pituitary gland. So it is, whether it is intracranial or whether it is extracranial, it is right in the middle of these two territories. So there is no terror of error in nature. So this location of pituitary tumor is not an erroneous or by mistake. There has been some purpose of this location. Like thyroid gland is located under the skin. Human testis is located outside the body. So it has some function to play. That is why that special location. Similarly, this pituitary gland is located in the vicinity of paranasal sinuses. And we have said that this is an air conditioner of the body. It gets information from outside about what is the temperature outside and what is happening outside. And this information goes to the pituitary gland. Cavernous sinus carotid artery gets the information about what is happening inside the body and gives information to the gland. And this master gland then ultimately directs the information all over the system of the body and conducts the functions of the body. So this might be, and there are several other issues that we have published, and we have written some beautiful issues about the location of the pituitary gland vis-a-vis its functions. So it is in the sella turcica, this bony shallow cavity for pituitary gland, and there is diaphragm celli covering it, carotid by the side, optic nerves by the side, and membranes covering it. So this is a very fantastic location of the pituitary gland. You see there is a pituitary stalk. Pituitary gland is quite a large structure and quite a hormone producing body which regulates. So it is a master conductor of the whole body. But when tumors happen, that is when we come in picture as neurosurgeons. Pituitary tumors can become large, and we have got several publications on the concepts of pituitary tumor surgery, particularly when they become huge and large in size. And there is no question in my mind that some of these concepts have completely changed or revolutionized pituitary tumor surgery. There is no question in my mind. And we have written several articles on this subject in various journals and on various forums. So giant pituitary tumor is a challenge in itself. It is a dangerous operation. It is a difficult operation. You can create beautiful human being after a successful operation, or you can actually kill the person. In neurosurgery, there are few instances where there can be postoperative deaths, and giant pituitary or large pituitary tumor is one of those very important instances where you have to know before operation, yes, there is a possibility of death. Yes, this is a pituitary tumor. You have to be able to diagnose this as a pituitary tumor. And there is a lot of controversy. Most of these large pituitary tumors become very huge in size. Small pituitary tumors like Cushing disease. You see Cushing disease, you remove the tumor, you create a complete cure. If you know how to remove a Cushing disease, that nodular tumor completely en masse, you have to go around. And this contribution of complete nodule formation by Oldfield was one of the very important landmarks in Cushing disease surgery. And you can cure the person. Or if you don't treat these Cushing disease properly, they die within 6 months, 8 months, these patients just die. So it is in your hand to understand, learn, and operate on these patients. So these tumor Cushing disease, you have to remove them as a nodule. You cannot leave some tumor behind. And if you are able to remove it completely and beautifully, there is a possibility of complete cure. So sella and cellar tumors, sometimes some tumors are easy tumors. Nothing is easy in neurosurgery, but these tumors can be removed relatively easily. There is sometimes diagnostic issues, and you have to know that whether this is indeed a pituitary tumor or it is not a pituitary tumor, or it's some lymphocytic hypophysitis, tuberculous hypophysitis, and things like that you have to understand before you come into picture. Supracellular cellular tumors, this is of course a meningioma, and this is my very favorite slides. They can slide that looks like an absolute lion on imaging and during surgery, but you have to learn how to tame this lion and how to get hold of this lion. And if you know this entity properly and absolutely you know the intricacies of this, you can remove this as a flower. And this is one giant in my giant meningioma. I may like to talk on giant meningiomas some other time on this forum, but meningiomas can be giant. And one of the meetings with Professor Kawase on meningiomas, I presented this case. And I told him in the meeting, in the foothills of Mount Fuji, I said that Indian meningiomas are bigger than Mount Fuji. So giant is the key word in my current discussion with you. So I'm going to show you some giant pituitary tumors. So I am taking you to the world of pituitary tumors and carefully have a look. So this is a huge tumor, and these are all, whatever slides I'm showing you are pituitary tumors. And you see, this is another giant pituitary tumor. This is another huge giant pituitary tumor. Another giant tumor. So what I'm going to do is I'm going to first show you some giants. And I'm telling you that these are pituitary tumors. And I want you to understand the anatomy of these tumors, which I'm going to explain to you in the subsequent part of my lecture. And then I'm going to show you these slides again for you to whether you have indeed understood my concepts of anatomy of these tumors. So this is another giant tumor. You see how it is growing and how it is involving various structures, how it is involving the carotid arteries, how it is involving the dura. This is another giant. You see how the tuber lobulations and what is the relationship of internal carotid artery. The relationship of dura is very critical here in this case, and how it is going up in the form of lobulations. This is another huge pituitary tumor. And I must tell you, I'm showing you this tumor, which is indeed very huge, but it is anatomically precise. It has absolute anatomical conformation. There is a method in madness in these tumors. It is not an intracranial tumor. It is not just a large tumor. There is a defined anatomy in these tumors. So this is another tumor. You see, it looks quite bizarre, but it is not bizarre. That is my concept, that there is a method in madness in the growth of these tumors. And if you understand that method, you will be able to remove these tumors in quite a philosophical pattern. And you see, this is another huge giant tumor. This is another one. This is another one going in the paranasal sinuses. So giant tumor is itself a burden on human shoulders and neurosurgeons' shoulders. And I have to tell you that if you do not understand these tumors, there is a distinct possibility of death following surgery. So let me give you my concepts of these tumors. For the first time in the literature, we mentioned that this cella, when the cella grows, the diaphragm cella dura is elevated on the dome of the tumor. So this entire tumor is under the diaphragm celli. This concept has absolutely revolutionizing effects on surgery. Like, for instance, the concept earlier was that there is a hole in the diaphragm celli, and the tumor erupts out of the diaphragm celli and goes in the suprasellar area. The concept was it is dumbbell-shaped. Half of the tumor is in the subarachnoid spaces, half of the tumor is in the intradural spaces. So we completely changed the concept that majority of these tumors, the diaphragm celli is elevated on the dome of the tumor. And I will show you several examples of this. Now you see this slide, which clearly shows how the diaphragm celli is elevated on the dome of the tumor. Believe me, this concept about pituitary tumor and its relationship with diaphragm celli was not existent 20 years or 25 years ago. And all of these tumors were operated by transcranial route. and not by transnasal route. Now, of course, people like to talk about endoscope and microscope, but the major game changer was not microscope or endoscope. The major game changer was the concept that you can remove this entire tumor from the nose, and ultimately this diaphragm celli will come into picture, indicating or signaling that the entire tumor has come. And this concept has completely revolutionized pituitary tumor surgery. So this tumor grows up and the diaphragm goes up along with the tumor. Even these kind of nubbins, this vessel is not inside the tumor. Imagine if it was subarachnoid, the vascular relation would have been quite intricate. But the concept is that there is a distinct and well-defined dural border which protects you during the surgery and which forms a limit for your surgery. So there is a dura, all the vessels, all the structures are around the tumor, not inside the tumor. So that concept has been the game changer. So this grade 1 tumor is when the diaphragm celli is elevated, the tumor is in the sella, even the sellar dura is preserved. There is a thin bone shell which is also preserved. So when you go first remove the thin bone shell, then you remove cut the dura and then enter into the tumor, and this diaphragm is the one which is going to protect you. So this, see how the tumor is going. The diaphragm is preserved. The tumor I call grade 1 unless it goes in the cavernous sinus. And what are the indicators of cavernous sinus invasion is when the internal carotid artery in the cavernous sinus is encased by the tumor. So diaphragm is elevated. The whole thing is under the diaphragm. Whole thing is intradural or subdural in location. You see this tumor, it looks bizarre. It is indeed intracranial. It is indeed suprasellar, but it is indeed subdiaphragmatic, which this word was never used in the literature earlier. So this is subdiaphragmatic, subdural tumor or with interdural. The entire tumor is within the confines of the dura. So grade 1, I call this tumor grade 1 when the internal carotid artery of cavernous sinus is not encased by the tumor. So this huge tumor is also subdural, or in the whole tumor is within the dural confines. There is no diaphragm celli border here. There is no artery here. All the arteries are around the tumor. Even when these lobulations are there, the arteries are surrounding the tumor. They are not within the tumor. This kind of lobulation is a dural loculation. It is also covered by the dura. Imagine this beautiful. This is, if you do not have, believe me, my dear friend, I know not many friends are here on the screen today, but whoever is there, believe me, if you do not have this concept that the dura covers the tumor, you cannot just imagine to remove this tumor, or you can create a big disaster. Your concept has to be absolute and absolutely clear that there is dura around this tumor. You see, there is a dural nodulation. There is dura around this tumor, which is such an important anatomical observation if you have to remove this tumor. So this subfrontal extension, 25 or 20 years ago, all these tumors which I have shown you were removed by transcranial route. There was no question of coming from the nose and transmural. There was no question. Nobody in the world used to remove such tumors with subfrontal extension. But if you have the concept that there is dura here, you can remove these tumors in very quick, maybe in 20 minutes you can remove this tumor. So these lobulations, majority of these tumors are soft, majority of these tumors are necrotic, several of these tumors are cystic. You see this dural border. You have to understand these dural lobulations, So this entire tumor is a kind of a ball. covered by dura. I will not say it is gas, but it is quite soft. It is liquid. It is a water balloon, a necrotic balloon. And I am saying that majority of these patients present with visual deficits, and majority of these patients will recover if you, in the vision, in the evening of operation, if you have done a beautiful operation. So these tumors can achieve large size, but they are histologically benign. The other very important thing is they are histologically benign, and your good operation can give a new life, a new vision to these patients. So you see these kind of tumors which have a very beautiful dural cover. The dura may be thin, dura may be thick, but dura is well defined and distinct and discrete border. Grade 2 is when the tumor enters into cavernous sinus, encases the internal carotid artery. Diaphragm celli is present here. Dura of the cavernous sinus is present here. So even now, the tumor is completely within the confines of the dura. So this tumor is completely interdural. It enters into this compartment of cavernous sinus. Nobody knows what is this compartment of cavernous sinus, whether it is extradural compartment, whether it is interdural compartment. This compartment of cavernous sinus is an enigma. So this tumor enters into this compartment and remains surrounded by dura. This is such a beautiful anatomical understanding. If you do not have this understanding, it is impossible for you to do this operation. This is lateral wall of cavernous sinus, which remains intact. This is within the dura of the cavernous sinus and within the sella. So what is medial compartment of cavernous sinus? We have written about it. This is cavernous hemangioma of cavernous sinus. It enters into the intercavernous sinus. It never goes and touches the sellar dura, the pituitary gland. That sellar dura protects this tumor. It is in the cavernous sinus. It goes in the intercavernous sinus dura, not into the sella. So why some tumors go into the sella and why some tumors from sellar tumor go into cavernous sinus? These are very controversial, very difficult to understand this story. So this tumor goes into the cavernous sinus. I call it grade 2. This tumor, beautiful tumor, I'm showing you. This lateral wall is intact. Diaphragm celli is intact inside the cavernous sinus. And this tumor is completely intradural or interdural in location. And you see these tumors can go into the sphenoid sinus or paranasal sinuses. I call them grade 2 tumor when the carotid artery is encased, diaphragm celli is intact, lateral wall is intact. You see this tumor is completely surrounded by dura. This is grade 2 when it goes into the cavernous sinus. Now I want to introduce another beautiful thing that we talked about for the first time in the literature about elevation of dural roof of cavernous sinus. This is diaphragm celli, elevation of dural roof of cavernous sinus. This entity was never discussed earlier. That this part of the tumor is also within the dura. You see this elevation of dural roof. This is elevation of diaphragm, elevation of dural roof of cavernous sinus. Elevation of diaphragm, elevation of dural roof of cavernous sinus. So when the elevation of dural roof of cavernous sinus is there, I call it grade 3 tumors. This is elevation of dural roof, elevation of dural roof of the cavernous sinus, elevation of dural roof of the cavernous sinus. It is not a bizarre or haphazard kind of extension. It has a definite pattern or definite method in this madness. You see elevation of roof, elevation of the diaphragm. This kind of elevations of diaphragms and elevation of roof of cavernous sinus was never discussed in the literature prior to our papers on this subject. So elevation of dura of the cavernous sinus, elevation of dura of the roof of cavernous sinus, elevation of diaphragm, elevation of dura of cavernous sinus. You see, there is a method in this madness. There is a method in this extension. This is not just a small haphazard kind of presence, but there is a covering of dura and covering of dura and covering of dura of the cavernous sinus. And this is another beautiful tumor, elevation of roof, elevation of diaphragm, elevation of roof of cavernous sinus. So this looks very bizarre kind of extension, but there is a clear pattern, elevation of diaphragm, elevation of roof of cavernous sinus. Understanding this extension and understanding of this pattern also, I showed you one picture. It was not just an intracranial extension, but it is a very defined elevation of roof of cavernous sinus. If you carefully study these images, you will know exactly what is happening. This elevation of roof of cavernous sinus is compressing over the chiasma. So if you do not remove this part of the tumor, vision might not recover. So this is a different case. See this kind of beautiful duck kind of tumor. And this part is the head of the duck, which is roof of the cavernous sinus. This is also roof of the cavernous sinus. Grade 4 is I call it aggressive tumor when the tumor does not respect the mother dura. It goes beyond the confines of the mother dura, beyond the grip of the mother dura, and goes and encases the arteries of circle of Willis. These tumors, I call it grade 4 pituitary tumor or aggressive or malignant pituitary tumor. Surgical strategy in these tumors is certainly different, and understanding of this tumor is certainly different. Encasing the basilar, so this is grade 4. So now about the surgery. How you will operate on this tumor? That is the question. Giant pituitary tumors can go in this, but they are confined. They are beautifully confined. That is the issue. Even when these tumors go in the cliver, in the paranasal sinuses, there is some. But one thing is, if the tumor has been operated earlier, the second time they may not respect the dural confines or margin, and the surgical strategy in these cases can be a little tricky. So this tumor in the paranasal sinuses also have a defined pattern. So this is my grading scale. Grade 1 is when it is under the diaphragm. Grade 2 is when it goes in cavernous sinus. Grade 3 is when the dural roof of cavernous sinus is elevated. Grade 4 is when it encircles the arteries of circle of Willis. This is my grading scale, and this anatomy of dura, anatomy of diaphragm sali, anatomy of cavernous sinus dura, in my estimation, has completely, radically revolutionized pituitary tumor surgery. So now about surgery of pituitary tumors, which grow large. So when they grow intracranial, it is like uterus. The natural pathway of this baby to be born is by vaginal pathway. Trans-abdominal or cesarean section is not a natural route of delivery of a child. You have never heard of elephant being delivered by cesarean section or a horse being delivered, because, you know, this is a little bit of a fancy or fad in human, where we want to do cesarean sections on every third child that is delivered. Uterus is the strongest muscle of the body, like diaphragm sali, is strongest part of the dura. And this dura, this mother dura, has the power to push this tumor down into your exposure. So my surgical strategy for these tumors is just have the exposure of anterior wall of the sella using microscope. I don't use endoscope. And then learn the art of breaking the tumor. Learn these are very soft tumors, necrotic tumors, vascular tumor. You will not imagine, but my experience is of more than 5,000 pituitary tumors. I have never used cautery during resection of these tumors. There is no bipolar, there is no, of course, there is no other instrument. Some people use unipolar. That instrument does not exist for me. So break the tumor, and the diaphragm will eventually come into the picture. And that is the end of the operation. You don't see any carotid, you don't see any circle of Willis during the operation. You only see the dura. You have to know how to break the tumor and how to preserve the dura. And in the evening of operation, this patient will have fresh new vision. And if you do incomplete operation, partial resection, half operation, these tumors will bleed and you may not be able to see this patient when you go for your evening rounds. So it is either the patient sees you or you see the patient, depends on how you understand these tumors. Many of these tumors are soft and necrotic. This kind of tumor, I think if you remove this tumor in more than 20 minutes, if you say I remove in 5 hours, if you remove in 5 hours means you do not know this tumor. You should not be doing this kind of stuff. This tumor is soft necrotic under the dura. You cut this, demolish this tumor in 5 minutes or 10 minutes, and you should be out within 15 minutes of this surgery. This tumor is also such a beautiful tumor to remove, such a game changer for such a gratifying surgery for the patient and for the doctor. In the evening, the person says, doctor, I can see better. This lobule, transnasal, open the dura, demolish the tumor, break the tumor. This tumor is completely within the sella. I think such an easy tumor to operate. I will not like to use this word easy, but it is such a beautiful tumor to operate and such a quick. This is another tumor. If you do not have this understanding that diaphragm is above the tumor, and you must have this understanding that we described it for the first time in the literature. Don't take away the credit of this description, which many people do not like to give, but have the heart to say that who described that the diaphragm celli is elevated by the tumor, and that is the reason you can remove this tumor in quick fashion, in a gratifying fashion. This pregnant tumor, I will say one of the more easier tumor to remove in the entire neurosurgery and most beautiful tumor to remove. Diaphragm remains intact. You don't even have to do any kind of reconstruction. The diaphragm is completely separating this tumor from the intracranial compartment. Remove the tumor, diaphragm in picture, no reconstruction. This huge belly, break the tumor, first break the tumor laterally, first break the legs of the tumor, and then the head come bowing down in front of you. So whether endoscope is necessary or not necessary, I have written about it on several occasions. But, even this tumor, I removed this tumor in 1998. At that time, all pituitary tumors, even cellular tumors, were removed transcranially. This tumor to remove by nose was an absolute beauty at that time. And you see, I removed this tumor completely in 1998, 25 years ago. This is another tumor I removed 22 years ago through the nose in a quick fashion, in a beautiful fashion. This is another huge tumor which I removed. Understanding that the dura is present, this tumor was also removed several years ago in a very quick fashion. This is another tumor. You see how the tumor, and I have to tell you, my dear friends, this tumor, I don't remember how much time, but it must not be more than 20 minutes this tumor would have been removed. This is another tumor beautifully removed. These have small necrotic, small cystic areas. Only remove the anterior wall of the sella, come laterally, break the legs of this tumor, the head and the diaphragm will come bowing in front of you in very quick. Learn how to break the tumor. Learn every tumor, not just pituitary tumor. Learn how to demolish the tumor. If you just go on coagulating like an idiot, you will never be able to remove these tumors. You see this tumor diaphragm cell is present, and this is post-operative. This is another tumor, diaphragm cell is present, and the tumor has been removed. Learn how to break the tumor. Learn how to break the tumor quickly. Don't use the instruments because they are in the operation theater. Use the instruments only when they are necessary and important. This is immediate post-operative. Some blood is there in this, but that blood will disappear in quick time. This is also immediate post-operative period. This is some blood, and this blood is going to disappear in quick time. So this is in the sala. This is post-operative. This is a huge tumor. You can imagine the beauty of resection, and this is also immediate post-operative, some blood. So this tumor I removed in 21 years ago. You can imagine I left some tumor behind. At that time, it didn't fall in my picture. And there is a recurrence in this. So very huge tumor can recur even if there is. So these kind of tumors is logically benign, but there is a large tumors, there can be recurrence. Even this tumor, you can imagine 21 years ago, I removed this tumor from the nose. This was the post-operative, some clot, and this guy disappeared. And he never came for a post-operative, but there was complete resection that is seen. In 2008, he came back with a recurrence. So these massive tumors, my philosophy is even if we have removed it completely, I might like to give radiation treatment. So these are some dangerous tumors. The question is, if you want to remove, you remove. If you cannot remove, you should not remove. You should not remove partially these tumors because partial resection can be indeed dangerous because of the bleeding that can happen. This was one tumor which I could not remove from the nose completely. So the next stage, I went from the transcranial route. I must tell you that these tumors can be, these large tumors, there can be a complication. And when there can be a complication, you have to know, and that complication can be absolute, a death sentence for these patients. How to remove cavernous sinus portion of the tumor is another trick of trade. And you have to know how to remove these tumors when it goes into cavernous sinus, how to handle, whether it should be removed is another issue. Whether you should enter into cavernous sinus and whether you should be removing the part in cavernous sinus. It is not always necessary that you remove cavernous part and put the cranial nerves in danger. But in functioning tumor, if you don't remove, you can have functioning tumors continuing to function. So this is cavernous sinus portion residue, non-functioning tumors. You can certainly, without any issue, there is no need to be too aggressive, but many of these tumors are soft, necrotic, easy. You can follow into the cavernous sinus. And this elevation of the roof of the cavernous sinus, this is some blood, not tumor. So elevation of the roof of cavernous sinus, this part of the tumor, is a little tricky. You don't come transcranial. The third nerve is very intimately associated with this component of the tumor. So you remain within the dura. The dura of tumor is discrete. Dura of third nerve is discrete. Dura of fifth nerve is discrete. And there is a clear separating margin. And you can remove these tumors. And also I have to tell you that whether to give radiation or not for these residual tumor is also a very highly controversial issue. The tumor in the roof of cavernous sinus, you see this tumor I had left behind. And the patient improved in the vision. I did not give radiation. But these tumors, grade 3 tumors, where there is elevation of the roof of cavernous sinus, these tumors recur very strongly. This is another tumor I operated in 2003. There was residue in the cavernous sinus and in the roof, and this tumor recurs. So my policy now is when there is a residual tumor in this third grade 3 tumors, I like to give radiation. Upfront radiation. You see, this is another tumor which is I had removed several years ago, and these tumors are beautiful tumors. There is no question. You see this elevation of roof. I removed this elevation, also this part, and this patient was observed. So my story of giant pituitary tumors revolves around these dural walls. And we have to understand these dural walls very beautifully in the cavernous sinus, in the roof of cavernous sinus. We have to understand these tumors. And this is a lateral wall being nubbined like this is a rare phenomenon. Never I have feeling this kind of thing has been reported in the literature. So this was one tumor which I did transcranial route because it was a little bit of a different kind of tumor. In majority of tumors, you can make a diagnosis of this tumor being pituitary tumor on the basis of anatomical extension, on the basis of clinical presentation. And of course, if you think that it is some other kind of malignant tumor or some other tumor, then you have to plan a different kind of surgical strategy. If you know it is a pituitary tumor, then you can just remove a small window of cellular dura and attack. And that attack can be complete. You don't have to do orbitozygomat. If you think it is some kind of other kind of tumor, then you will have your approach strategy will be different. Now, of course, many people like to use endoscope. Whether that is a very small issue in neurosurgery. I like endoscope, I like microscope. Understanding of the tumor, philosophically following the walls of the dura is the issue. And when to give radiation and when not to give radiation is another very important component of these tumors. Grade 4 tumors are when the artery is encased by the tumor. These tumors are like cobra. You enter and you can kill this person very dramatically. So how to do, what to do is another chapter of neurosurgery and another still evolving. But now what my understanding is, many of these tumors are hormonally active and prolactinomas can have this kind of bizarre kind of extension. So this tumor, the prolactin level was 32,000. Even if it is more than 150, you can consider it prolactinoma and try cabergoline and drugs like that. So this tumor, you see grade 4 tumor, this is treated by drugs. And there are some more tumors in my series now where we have treated with drugs, and you have to understand when to investigate for when to treat with drugs. So danger issues in giant pituitary tumors is one where it is very big, higher grade tumor. When the patient is drowsy, it is a danger issue. When the patient comes with altered behavior, dangerous issue. When the patient comes with hypothalamic disturbance, do not operate this tumor, may be a better option. So these are my indications for radiotherapy. And this was a smallish reconstruction technique using vascularized dural flap, which we adopted. And now my colleagues, of course, not me, have worked on proteomics of these tumors. And this study has resulted in several articles on the subject. And I will rapidly show you some images of cysts and fluid level in these tumors before I end. I know it has been a little bit of a large tumor, of course, but largest lecture also. So now see this slide. There is a fluid level in this tumor, fluid level in this tumor, fluid level, fluid level, fluid level, fluid level, fluid level. So many of these pituitary tumors have a fluid level. And when there is a fluid level, these tumors are more aggressive. Much more easier to remove because they are soft, necrotic. You can remove them very rapidly. If the rest of the tumors are removed in 20 minutes, these tumors can be removed in 10 minutes. That kind of, it makes the thing easy, but the possibility of recurrence is very high. So let me show you rapidly some pictures of fluid level. You see there is a fluid level. There are two fluid levels in this case. There are multiple, all small cysts. All these cysts are having fluid levels. This tumor having fluid level, grade 3 tumor. This tumor has two fluid levels. So this tumor, when you operate, it is a soft, bloody tumor. It will rapidly come out. And then the wall, there will be reddish colored tumor, and you remove that tumor. It is relatively easier tumor. You see there is a fluid level, fluid level, fluid level, fluid level, fluid level. So there is a fluid level in this tumor. There is a clear, distinct fluid level. There is a fluid level in this tumor. There is a fluid level here and a fluid level here. There is a multiple fluid levels in the tumor. You see this tumor, large tumor with fluid levels, patient with head supine. So all these fluid levels are in one direction. All the fluid levels are vertical because the patient is supine. You see its fluid levels, and all these small cysts have fluid levels. This is very characteristic of a pituitary tumor. See this tumor having fluid levels. And when there is a recurrence, also there is a recurrence with fluid levels. So there is a fluid level. The fluid level here in the cavernous sinus, fluid level in the sala. Beautiful fluid level, beautiful fluid level. Another tumor with multiple cysts with fluid level here. Beautiful fluid level here, and you see how this tumor, and this is fluid level here and in the sala. This is this kind of tumor having even the cavernous sinus part of the tumor having a fluid level. So I think I have shown you this image, and this tumor also with fluid levels, and that is the beauty of these tumors. So I have reported fluid levels in several tumors. So I think I will like to end at this point, and I hope you enjoyed this presentation. So thank you very much, my dear Marco and John. John, by now you must be expert in neurosurgery with all these tumors that I have been showing you. And but this is the beauty. What do you think, Marco? What is your, tell me what you have heard and what you have learned from this lecture. I will be, and even I see Takashi on screen. So I will like to have Takashi also giving some impressions. Yes, Marco, tell me.
Well, good. Was incredible to see your performance, Professor. It's really incredible. Most of all because we know the current new concept that the new surgeries regarding to endoscopic surgery have brought to the new treatment for pituitary tumors. So it's really amazing to know that there is a different approach to this kind of tumor, because it's well known that most of the neurosurgeons in the new era are bringing the endoscopy surgery as the gold standard for pituitary tumors. So here we have a different approach. However, Professor, I will have to like a question. For example, what would be your thoughts related to prolactinoma, gigant prolactinoma? Because we know that now there are a few new concepts regarding to when to treat surgically, even though that some surgeons, they still saying that don't give up on cabergoline. However, there are a few cases that are needed to do surgery in cases of gigant prolactinoma. Which one will be your thoughts on?
Yeah, this is a very important question, and the whole world is discussing on this. You see, sometimes the person comes with gross visual deficit and you see a large tumor and a necrotic tumor, which is such easy operation, quick operation, and the vision improves immediately after the surgery. On the other hand, drug treatment is also very effective. And if you know, cabergoline, you start drug in 2-3 weeks, the system starts working and the vision starts normalizing. I have treated huge tumors with visual deficit, with drugs, and with very effective treatment. So if the prolactinoma is clear, if the values are quite significantly high, and you know, cabergoline and drug treatment is indeed quite an option, unless the vision is going down rapidly and it has gone to a very high extent and the tumor is readily there to be picked up like a cherry. I think do it. So it is a choice between you, patient, and the drugs. I think surgery also has a very distinct role in prolactinomas, but drugs have also a very high, you know, if suppose a person comes with vision down for 2 months or 3 months, you can certainly you wait for another week or two to start drugs and the vision will start recovering quickly. So, drug treatment is very effective. And I think surgery should be not the immediate jumping on surgery or first option in many of these cases, in majority of these cases.
Okay, Professor, thank you, because that's a very controversial subject right now, because I have seen cases published that are giant prolactinomas, even with these huge values in the prolactin hormone level, even more than 4 units, say 4,000, 5,000, 10,000 of nanogram of prolactin. And even though some surgeons, they still stating, don't give up on cabergoline, just keep giving it to the patient the cabergoline. And eventually, if there was going to be a lot of improvement. However, there are other surgeons that currently are saying that there are some aggressive prolactin. That's the new picture they are bringing now to this new era of the surgery, endoscopic surgery. This aggressive prolactin, that most of them say that this gigant prolactin is pretty invasive to the cavernous sinus, even with the suprasellar growth, even to the anterior pulsa or the middle pulsa. They say this tumor, even though that you treat it with cabergoline, this lateral extension or anterior posterior extension is going to be really hard for this patient to be reduced under the medication. So those patients, and because some of the characteristics of the tumor by itself are like non-mandatory, but will be available to surgery. And also they will state in that patients under 20 years, like most of them, like pediatric patients or Persian patients under 20 years with this characteristic will be manageable to do surgery. I don't know, this is a very controversial thing.
Let us hear what Takashi has to say. Takashi, are you there?
Yeah, good evening. Good evening, Dr. Goyer. So thank you for a great lecture. We experienced very few experience about such a huge pituitary tumor, but sometimes we encounter a large pituitary tumor and combined craniotomy and endoscopic surgery are done. Usually, pituitary adenoma is very well demarcated and very soft and easy to sucking, but sometimes very fibrous. Before using cabergoline for a long time, tumor became fibrous and very difficult to remove. But our experience is very not so much. So I learned a lot. I've never experienced such a huge upper pituitary adenoma, but they are well demarcated. The diaphragms are very easy based on the anatomical structure. So I learned a lot about basically microsurgical structure anatomy. Thank you for the lecture.
Thank you, Takashi. Thank you so much. You know what? These tumors, pituitary tumors, can indeed become very firm if there is some cabergoline, some drugs have been given to the patient and long-term drug treatment. They can become very elastic and dangerous on some occasion. But in general, pituitary tumors are not like meningiomas. Pituitary tumors are not like, they are soft tumors. They are cystic, necrotic tumors, and you can easily remove. You have to remove it. And also your understanding has to be great. You have to be sure that you have removed it radically and completely, because partial resections can be quite dangerous in pituitary tumors, and you can have, an intracranial, particularly if you have done transcranial route, there can be a possibility of death post-operative, and that in large giant tumors. So you have to, these are benign tumors, and these are non-functioning tumors. They come with visual deficit. If you do a good operation, vision can be improved and the patient can be survive for a long number of years. So that is the story. Takashi, nice to have you. How are you? Everything okay?
Yeah, we're fine. So it's 2 a.m., but I want to listen to lectures, so I stay up later.
Dedication.
Any other question for me, Marco?
Here we have Professor Silvia Salva. She's another neurosurgeon from Cuba. She has also a PhD in radiosurgery. So, Professor Sylvia, can you say some thoughts here?
Hello, good afternoon to everybody. Hello, Professor. It is a huge pleasure to be today with you. I'm agree with you. The surgery is the main concept in hypophyseal tumors. Surgical resection is the principal treatment. I think radiosurgery is only a treatment when the surgery is not possible, when the comorbidity of the patient are severe, or when the patient, when radiosurgery is a choice patient. I don't agree with you.
Thank
No,
you,
really,
Professor.
Thank you, Dr. Sylvia. And we have to just learn and grow and think and progress, and we have to do it together. We have to learn from every corner of the world. That is why I'm asking Marco to invite me to Cuba, and I want to see your beautiful country.
No, definitely, sir.
Hey,
And
he'll
I
come.
want to-
Hey, he'll come. He'll come, Marco. He's not just saying that.
and also, Professor, of course, the invitation is there on the table, because also Cuba has a lot of improvement in pituitary tumor surgery, mostly in endoscopic Indonesian approach. We have few places in Cuba actually right now doing endoscopic Indonesian surgeries, and they have quite a lot of experience right now, and that would be amazing. That would be amazing to share that knowledge with a professor like you, and of course everyone is invited to go there and honestly to share that knowledge, because it's important, because it's not only the experience that our institution in Cuba might have, but also to share and like combine all those experiences between Professor Goel and whatever decided to go there and to share. It would be amazing. We could have made the arrangement, Professor. It would be amazing, honestly.
Thank you very much, my dear Marco. And,
it would be a long trip. Honestly, it would be a long trip.
John can accompany me. John, you think, are you ready?
Well, it's just a little boat ride to Cuba.
And Takashi, of course, you're invited too.
Thank you. So we want to visit someday. So I've been to Key West. I've been to Key West and Miami. So a
You've
little
been
more.
to Cuba? You've been to Cuba?
Yeah, a little more to Havana. Mm.
Oh, wow.
Yeah, very exciting.
Okay. So we could try and like try to gather as much as professors, like for example Goel, even Professor Borba. We could talk to him, to Professor Borba, and try to encourage him to go to Cuba and see what the Cuban neurosurgeons are actually doing. Would be amazing. Just to have Cuba on board.
It's possible, Marco. Anything's possible today with the internet.
Exactly. And of course, most importantly, John, thank you to your platform, which is making this huge connection, is creating this connection between all our cultures, because that's one of the most amazing things you are doing with your platform. And of course,
it's my pleasure. It's my pleasure.
And of course, always be thankful to Professor Goel for his time. I know right now it's around 12, right? It's around 12.
Yes.
So,
late. It's late. Yeah.
Yes,
okay.
I would like to propose Professor Goel to bring a subject about craniopharyngioma, because it's hugely amazing. And I will try to see if I could bring one of the Cuban neurosurgeons that actually currently has an amazing work in craniopharyngioma surgery, so we could have different perspectives, and it would be quite amazing. What do you think, Professor?
Yeah, we could do that after next Sunday. Dr. Goel's lecturing in China with Dr. Ben.
I will be there. I will be there.
Dr. Ben. So maybe not next Sunday, maybe the Sunday after.
Yes, of course.
Okay. John has to give instructions, and they will be followed.
There you go.
Okay,
we're
John.
covering the globe. We're covering the globe, Atul.
Bye-bye. Good
Thank
night.
you,
And
Atul.
Thank
you.
you.
good morning to you.
Thank
Bye-bye.
you. Thank you, Professor.
Bye-bye. Bye-bye.
Bye.
Bye. Thank you.